All right, good evening, everyone. Welcome to our webinar presented by Dr. Ghufran Al-Hashmi. My name is Rawan Hafiz. I'll be the moderator for this webinar. It's my pleasure to introduce my friend and colleague, Dr. Ghufran Al-Hashmi. Dr. Ghufran is a pediatric radiology consultant and assistant professor at King Abdulaziz University Hospital. She specializes in pediatric radiology, and she did her pediatric fellowship at Sick Kids in Toronto, followed by another year at Cincinnati Children's Hospital. One of her interests is fetal imaging, and she did further training in that too, which she excels at, to say the least. We're very lucky because she's also an excellent teacher and one of the drivers of our continued learning and academic growth in our unit. So without further ado, I'll give the mic to Dr. Ghufran, who will be talking about introduction to fetal MRI.
Thank you, Dr. Rawan. And thanks to the RSSA for this opportunity. Do you see my screen, Rawan?
Yes.
Okay, I'm on top. All right, it would be my pleasure today to be with you to go over an introduction to fetal MRI, which is one of my favorite topics. These will be my objectives. And I wish to achieve that by going through this outline. First start the talk by I like to start the talks by questions, and our first very relative question would be, what do you think the name of this fish? And you can answer the questions at the chat box, and we can go over the answers later throughout the talk. So you think this is a mackerel, this is a puffer fish, this is a boxfish, or a butterfly fish? All right, we'll go over a short fetal MRI history. So in 1977, the first MRI scanner was made, and in 84, it was FDA approved. And since the 1980s, there has been attempts to perform fetal MRI, but they were all limited by the slow sequences available at that time. So shown here is an example of a fetal MRI image published in the Lancet in 1983. They attempted to do a fetal MRI. They thought at the time that they had good fetal details that were greater than that seen by ultrasound. And they thought that at the time, these images can improve their knowledge of fetal development. They also thought that due to the absence of ionizing radiation and the superior tissue definition compared to ultrasound, that MRI would have wide applications in obstetric practice in the future. So since the 1990s, faster sequences were able to be made, and since then, fetal MRI images have been evolving. So why bother with doing a fetal MRI if you already have fetal ultrasound? So both MRI and ultrasound utilize non-ionizing radiation, and they both can provide us with multiple imaging planes. However, MRI, as you see in this image, is able to obtain a larger field of view image versus the limited or the smaller images that you can obtain with an ultrasound. And MRI also has excellent tissue contrast, which can enable distinguishing blood, fat, meconium, and cartilage. Also, MRI is not limited by maternal obesity, by fetal bones or fetal position, and is less limited by oligohydramnios compared to ultrasound. So we can use MRI to confirm or exclude the presence of lesions that are noted by ultrasound, and to demonstrate additional anomalies that are unable to be visualized by ultrasound. which can help us in prenatal multidisciplinary consults and help us plan fetal interventions, delivery, and postnatal therapy. It will also help in counseling parents. It can also decrease the need for postnatal imaging if the neonates are unstable. Currently, the strongest utility for fetal MRI is for CNS anomalies and for cases that are being considered for fetal interventions. So when looking at fetal brain MRI, and the added value of that compared to ultrasound, there has been a meta-analysis of 27 articles where prenatal MRI and ultrasound were compared. Both MRI and ultrasound agreed completely in 65% of cases. However, in 23% of cases, MRI showed additional or different pathologies. And in 8% of cases, MRI actually rejected the ultrasound diagnosis with a normal brain as the conclusion. My friend, Dr. Rawan, actually recently had a case which was referred for MRI with questioned brain anomaly on ultrasound, and the MRI was actually normal. When comparing ultrasound and fetal MRI to postnatal diagnosis, there was complete agreement between the fetal MRI and the postnatal diagnosis in 80% of cases, compared to only 50% of cases of fetal ultrasound. And additional abnormalities were found on postnatal imaging in only 14% of cases after fetal MRI, compared to 36% of cases after fetal ultrasound. So the name of this fish is actually Indian mackerel. These fish, they swim in school, and when they want to feed, they open their mouth wide open. You can almost see through their mouth into their guts. Under the sunshine, under the sunlight, they are very silvery, and so they have a nice shine to them. These fish are really nice to see underwater. Okay, so in regards to safety of fetal MRI, three concerns do arise when thinking about fetal MRI. One is whether it's teratogenic or not. The other is there a harmful effect related to tissue heating from the magnetic gradients applied, and whether there is an effect of the acoustic noise during MRI that can lead to hearing impairment in the neonates or fetuses. So a few animal studies have shown some harmful effects of MRI during gestation. However, these are not applicable to human and cannot be extrapolated, but they actually do raise concerns. There's currently no evidence of harmful effects to the fetus. However, the long-term safety hasn't yet been firmly established. Looking at fetal MRI safety, this study published in 2016 with a large number of fetuses exposed to fetal MRI showed that there was no increased risk of harm to the fetus or risk in early childhood when the fetuses were exposed to fetal MRI. However, they did find that gadolinium during pregnancy was associated with increased risk of rheumatological diseases, inflammatory and infiltrative skin conditions, as well as stillbirth and neonatal deaths. So the use of gadolinium during pregnancy is not recommended unless absolutely needed, particularly in early gestation. Regarding acoustic noise effects, multiple studies showed that there was no increased risk of neonatal hearing impairment when fetuses were exposed to 1.5 Tesla MRI or 3 Tesla MRI and there was no difference in the hearing impairment between the MR-exposed neonates and the control neonates. So a common question that we get asked is, what is the optimal timing to perform fetal MRI? The optimal timing actually depends on the clinical question to be answered. And because of the theoretical risk of MRI is potentially greatest during organogenesis, and some anomalies may not evolve yet during early gestation, and also because of the size of the fetus is very small before 16 to 18 weeks of gestation, fetal MRI is limited prior to that, and we don't prefer to do it before 16 weeks. So we do it anytime after 16 weeks, and we can do it up to the third trimester. So again, we do fetal MRIs after 16 weeks of gestation. Whenever an abnormality is detected by ultrasound that is seen by an experienced sonographer, and raise questions that could benefit from evaluation by MRI. We sometimes prefer to do it in the third trimester. That is in the cases where anomalies of the cerebral cortex are questioned. Also, when we're evaluating abnormalities that were seen earlier, but need to be imaged later to help planning delivery, such as cases with neck masses and cases that need exit procedure. When we do it in the third trimester, the benefit is that there would be less motion artifact, and it would also reflect more the postnatal appearances. And so with that, it can decrease the need for postnatal imaging, which can sometimes use ionizing radiation, can sometimes need anesthesia, transport, and monitoring. So overall, it can be associated with less cost. The down effect of doing fetal MRIs in the third trimester is more stress on the mom, because she's been waiting longer to do this fetal MRI, and because of the size of the larger gravid uterus while she's lying down to do the MR. And also, when we do it late, we risk being too late for intervention if an intervention would have been needed. What sequences do we use to perform a fetal MRI? So we use a combination of gradient-based and fast span echo-based sequences to image the brain and then move on to the body. So we image the brain with a combination of trophy sequence, such as the one showed here. Trophy sequences, the good thing about trophy sequences is they are obtained fast, and they can image larger fields of view. However, they are limited by the spatial resolution. So we add usually to the trophy haste images, which require more time. However, it has more spatial resolution. We also add diffusion sequences, which can enable us detect ischemia, for example, prenatally, and help us in cases such as renal agenesis, for example. We add as well sequences that can enable us to detect hemorrhage, such as SWI sequence. We also add T1 sequence, which can show us fat, hemorrhage, and in the body, the T1 sequence shows us the bright T1 signal of the meconium and the liver. So it can help us in making certain diagnoses. What are the limitations for fetal MRIs? MRI is limited by the technical challenges that are related to motion artifacts related to the moving fetus. It's also limited by the limited fast sequences that we currently have. the small size of the fetus, that is a small target, gives us images that can have low signal to noise ratio. So we need to work around that. And it's also limited by the lack of widespread technical experiences to perform these MRIs. The moving fetus also adds to the challenge, because sometimes you do the sequence and then you find that the baby moved and the plane is not as what you wanted, so you have to repeat the sequence. So that can add to the scanning time. It's also limited by maternal discomfort and anxiety. Question is, what is the superpower of this crab? So these are the options: fashionista, decorator, master of disguise, or all of the above. Moving now to the indications of fetal MRI. So the indications for fetal MRI are wide and are still evolving. A list here is shown showing multiple indications throughout the fetus, from the brain to the spine, face, thorax, abdomen, MSK, twins, pregnancies, planning of fetal delivery, some maternal indications as well. So the indications are wide and are still evolving. However, the three most common indications for fetal MRI currently are for the evaluation of ventriculomegaly, posterior fossa anomalies, and agenesis of corpus callosum. So we'll go over some cases to show examples of these indications. Shown here is a patient who was referred at 30 weeks gestational age. Ultrasound showed bilateral ventriculomegaly, a UGR, and polyhydramnios. So this is a coronal image showing polyhydramnios. That's a lot of amniotic fluid around the baby. The next image is showing that at 34 weeks gestational age, this baby brain is very smooth. You almost see no sulci at all. You also see diffuse band heterotopia. This sagittal image shows retrognathia. And also in this coronal body image, you see that there is eventration of the diaphragm bilaterally. So MRI was able to find the definition, the reason for this patient's ventriculomegaly. The patient had lissencephaly and band heterotopia, along with other multiple abnormalities. Compare this smooth brain of the patient I just showed you to a normal brain of a patient who's 32 weeks gestational age, where the sulci are well developed. This is a postnatal brain ultrasound image of the same baby showing the lissencephaly. Another patient and another indication that we perform MRI for is twins pregnancy and its complications. So this is a patient with twin transfusion syndrome, underwent laser ablation. The donor had IUFD and the recipient had marked hydrocephalus on ultrasound. So this is the MRI of the twins. Here shown is the IUFD donor, and here's the ex-recipient. And this is the brain of the ex-recipient, and you notice that the main abnormality for this fetal brain is that there is barely any, if at all, residual brain parenchyma. There is severe loss of the brain parenchymal volume, leading to the ventriculomegaly seen by ultrasound. This is a patient who was referred for ventriculomegaly assessment. And you can immediately see that there is bilateral colpocephaly on this axial brain image. And you see that there is a parallel configuration of the lateral ventricles. You notice on these coronal images that there is a tear horn appearance of the frontal horns. And on the sagittal image that there is the radial or sunray appearance of the sulci and gyri. So this is all in keeping with corpus callosum agenesis. And actually, on none of these images, you see a corpus callosum. This patient also had paucity of white matter volume in the posterior brain. So MRI was able to make the diagnosis of corpus callosum agenesis as the cause of this patient's ventriculomegaly seen by ultrasound. This is another patient who was referred at 24 weeks gestational age with question Dandy-Walker. They saw a posterior fossa cyst, and that's why they thought that there is maybe a Dandy-Walker. However, the fetal position was not optimal for good visualization, so they sent the patient for fetal MRI. So on this coronal image through the posterior brain and the posterior fossa, you see that there is a cystic structure in the posterior fossa. However, this cystic structure seems to be in continuity with the lateral ventricle. Not only that, you see that the medial wall of the left lateral ventricle is dehiscent. On the sagittal image, you pick up that opposed to Dandy-Walker malformation, where you have large posterior fossa, this patient actually has small posterior fossa. Not only that, there is actually hindbrain herniation. The brain images showed a lemon-shaped appearance of the skull. And this image shows better the dehiscence of the medial wall of the left lateral ventricle. So seeing these findings points to the diagnosis of Chiari too. So we were looking to get further images of the spine of this patient to see if there is an associated neural tube defect. And sure enough, you see on this sagittal image and on this axial image of the lumbosacral spine that there is an open neural tube defect without an overlying sac. So we were able to make the diagnosis of open neural tube defect and Chiari 2 malformation prior to delivery. So they were able to refer this patient to neurosurgery and plan the delivery, and also counsel parents that this patient will be born with an open neural tube defect. This is a 24 weeks age patient referred from ultrasound with ventriculomegaly and a posterior fossa cyst. So in this coronal image, you see that there is bilateral severe ventriculomegaly. Also, the third ventricle is dilated, and you don't see the septum pellucidum. On the sagittal image, you see that there is a large posterior fossa cyst that is communicating with the fourth ventricle, and you also notice that the tentorium is elevated. On this axial image, you notice that the vermis is absent. So this case is along the continuum of Dandy-Walker. Compare this posterior fossa with the large cyst to the MRI I just showed you of the patient who had the cyst that was herniating from that was actually like a herniation of the left lateral ventricle into the posterior fossa with a small posterior fossa. So there are other indications that are outside of the CNS that we can that can benefit from fetal MRI. We'll see some of them here. So this is a patient referred at 24 weeks gestational age with question congenital high airway obstruction. And sure enough, on the fetal MRI, you see that the lungs are large and the diaphragms are everted, and you see a large amount of ascites. You also see that the fluid-filled airway is discontinuous at the level of the larynx. This is a coronal image, and this is the fluid-filled airway, the trachea, and then you cannot trace it superiorly. It's not fluid-filled anymore. It's obstructed at this level. The same thing is shown here on the sagittal image. So that was an example of congenital high airway obstruction that's confirmed by MRI, showing the exact location of the obstruction. Shown here is a patient referred at 30 weeks gestational age. On ultrasound, they found what looked like possibly left isomerism on cardiac imaging. And then in the abdomen, they saw a large multicystic structure in the right side of the pelvis. And they were not able to see the right kidney. So they were thinking that this patient might have multicystic right kidney. So in this coronal MRI of the baby abdomen, we see here a normal right kidney. So this patient does not have multicystic right kidney as they were thinking on ultrasound. The T1 coronal image of the patient's body shows us that the meconium-filled colon, which has T1 hyperintensity to it, it's all in the right side of the abdomen. And we also see that all the small bowel is in the left abdomen. So MRI made the diagnosis of bowel non-rotation prenatally. Also, in the same patient, the sagittal images of the spine showed that the conus is blunted and that we were not able to see sacrum. So MRI also added to ultrasound the diagnosis of coded regression, in addition to the bowel non-rotation. And MRI excluded multicystic right kidney. Another example of our non-CNS related indications for fetal MRI is this patient who was referred at 34 weeks gestational age with dilated bowel and a negative target sign on ultrasound. So they were questioning imperforate anus on ultrasound. So on MRI, we see this sagittal haze image, and this is the rectum, and this is the urinary bladder filled with urine. So behind the bladder is the rectum, and the rectum should be dark on this sequence because it's filled with meconium. So normal meconium-filled rectum should have a dark signal on this image. However, in this patient, the signal is not dark, it's intermediate to high. This is the same patient, but this is a coronal image, again, showing us the urinary bladder here, and this is part of the rectum shown here, having high T2 signal instead of normal dark T2 signal. So this finding on fetal MRI is actually associated with imperforate anus and the presence of a rectourinary fistula, contributing to the high signal of meconium on fetal MRI. And this was actually confirmed postnatally, the imperforate anus and the presence of a rectourinary fistula. Compare our patient I just showed you, who has a high T2 signal in the rectum, to this normal patient with a dark T2 signal in the rectum, which is a normal T2 dark meconium. Other indications that we can use fetal MRI for is congenital diaphragmatic hernia and the evaluation of the content of the congenital diaphragmatic hernia, whether the stomach is up, whether the liver is up. And on these cases, we also measure the lung volumes. And these findings help give a prognosis to the neonatal care team and to the OBGYN. And so they can use it to guide treatment decisions and guide counseling. Another use of fetal MRI that can be done is in the evaluation of conjoined twins. However, this is not common, alhamdulillah. Other uses for fetal MRI can be in congenital infections. It can be as well useful in abdominal masses, in ventral wall defects assessment, in GU anomalies assessment, and assessment of skeletal dysplasias and syndromes. What is the superpower of this crab? I'm not sure what you all answered, but the answer is actually all of the above. This crab is called a decorator crab. The crab has these things that are like Velcro extensions that he has, and then he puts things on top of his back to camouflage, so he can put like even other structures. Like in this one, he's putting a sea urchin, a complete sea urchin on top of him, so he uses him as a defense on himself. And at times they put things to camouflage with the environment so they cannot be seen. So this is a decorator crab. So with that, I went over the outline of the talk, and in a nutshell, I want you to know that fetal MRI is a useful adjunct to ultrasound, and there is currently no evidence of harm for the use of fetal MRI when it's indicated. However, the evidence is still in progress, and there is currently no long-term safety data available. The use of IV contrast is not recommended because it's associated with adverse outcomes. And we can do fetal MRIs anytime after 16 weeks, whenever we think it can help. So whenever you encounter an abnormality on ultrasound that you think might be useful to evaluate with an MRI, consider consulting your radiologist. So the use of fetal MRI and its indications are wide and are still evolving. And currently it is strongest for CNS anomalies evaluation and when fetal interventions are needed. And with that, I hope that I met my objectives. And I thank you for your time and your attention and your interest. And I'm happy to answer any questions if there's any.
Thank you, Dr. Afran, for an amazing talk. We do have some questions, and I invite you guys to type in your questions in the Q&A, and I'll address them to Dr. Afran to answer. So the first question we have is there any atlas reference that can be used to assess cerebral cortex, cortical cell side development appropriate for fetus GA, gestational age in cases of fetal MRI?
Yes, there is. And there's actually also a nice fetal MRI book that I can, so the name of the book is, what is the name of the book, Rawan?
Was it, yeah,
I can find it and paste it and share it in the chat now. So there is actually, and we use that in all cases. So in all cases, we look at the gestational age and we compare to age-appropriate atlas. That's correct.
Okay, the other question is there specific measurements or values to assess for amount of amniotic fluid?
So there are studies for fetal MRI evaluation of amniotic fluid volume and correlating these MRI-based measures with the ultrasound. However, we commonly just look at it subjectively and assess it. And it's actually usually known already on ultrasound before we do the fetal MRI. So we never do fetal MRI without an ultrasound. So the answer is yes, there are studies for references, but in practice, we commonly subjectively evaluate it and correlate it with the ultrasound findings.
All right, thank you. And then the other one is, what is the best method to look for fetus position to rule out isomerism?
So the protocol to perform our fetal MRIs include images of the uterus that are axial, coronal, and sagittal. So these are anatomic images of the mother. So we compare the baby to the mom, and so with that we look at where the expected right and left of the patient is relevant to the mother, if the baby head is up or baby head is down. So sometimes we actually use like a mini doll or something in our hands, and then we put the baby doll head down, for example, is if the patient is cephalic presentation, and then we put also the back of the baby where expected, relevant to the mom, right or left. So with that, we are able to tell where is the right and left of the fetus should be, and see if the stomach is on the left side of the fetus, and the heart is on the left side, and the liver is on the right side, and such things. Regarding the cardiac anomaly of left and right isomerism, if this was part of the question, I don't do cardiac MRI for the fetus, but there are people who do that.
All right, thank you. Then is there any preparation for fetal MRI?
The preparations vary between institutions. In our hospital, we just ask the mom not to have coffee or tea the day of the examination. We also tell her that she will spend at least 30 minutes in the magnet. And before she goes into the magnet, we ask her to empty her bladder so she can be comfortable during the exam. Some institutions ask the mom to be fasting, but there are studies, the results of the studies in regards to fasting are not similar to each other. So some studies showed that fasting can help with the baby not moving a lot, and others have shown no difference. So we don't ask the mom to be fasting. We just ask her not to have coffee or tea.
Mm-hmm. All right, next question. Thanks for your great talk. Do you or any other RADs have experience with giving light sedation, like Valium, to pregnant women before getting in the magnet?
Earlier, when the sequences were not as fast, maybe they used to do sedation, but now we don't do sedation just to image the baby, because we use sequences that are supposed to be good enough to freeze the fetal motion. And if the images were not good the first time, while we're scanning the patient, we're actually monitoring the images. If the images are good, we don't need to repeat it. If there's a lot of motion that is limiting the evaluation, we ask the technologist to repeat it. So we don't do that.
Mm-hmm. All right, another one is, what are the main sequences for fetal cardiac pathologies or anomalies do we have to look at? So we don't do cardiac, but you can go ahead and answer.
Yeah.
Yeah, so yeah, we don't we don't usually do cardiac. I think they usually do the fetal echo to look
أيوة.
for pathologies.
I haven't been trained to do cardiac MRI in the fetus, but there are people who do that who may be able to help you.
All right. If you have discrepancy in gestational age, ultrasound and MRI, what should we do?
It depends on the gestational age that is given by the obstetrician or the MFM. So that is the gestational age that we use for our calculations. So our measurements can be either small for age or large for age, but they are small or large for age depending on the gestational age given to us by the MFMs.
Yeah, because we usually don't measure the gestational age on the MRI. It's like
we don't measure the gestational age. We depend on the age given to us, and then we compare the measurements of the fetal head, for example, to the standard for the same gestational age, and then we say it's normal for age, small or large.
yeah. All right. In what cases do we need to use contrast for fetal MRI? Is there any specific pathologies?
Don't.
Yeah.
We don't, because it's associated with adverse effects. So if there is a need to utilize contrast for other reasons other than fetal MRI, can be used, knowing that it is associated with adverse fetal effects.
All right. I guess the last one is the same if the contrast is indicated. So it's not as Sarah said. All right. That was all the questions. Any other questions or?
The name of the book is Fundamental and Advanced Fetal Imaging. And it is the lead author is Beth Klein.
Yes, it's
this
a very
book
good.
Has the atlas you were asking about, and also the reference measurements for fetal MRI and ultrasound as well.
All right. If there are no more questions, I guess we can conclude. Thank you so much, Dr. Ghufran, for such a great talk. I really enjoyed it.
Thank you, Dr. Rawan, and thank you all for your interest. It's been my pleasure.
All right. Bye.